In this episode of the ASC podcast with John Gailey, AAAHC has released v45 of the standards with brand new artificial intelligence requirements and a December 15th effective date. And it's a big week around here too. A new ASC Central website, the 2026 survey guide, and our September conference week. Then John talks with Amanda Penrod about leading across generations, how to mentor, retain, and get the best from a team that can span 4 decades of experience.
Welcome to the ASC Podcast with John Gailey, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 286 of the ASC podcast with John Gailey. We're recording today, August 19th, 2026, from our studios in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As always, the regulatory environment for ambulatory surgery centers continues to shift and evolve. The information we share in this episode is current as of the time of recording, but we encourage all ASCs to stay alert and monitor for any new or updated guidance from the relevant regulatory agencies. Joining me today, as always, is John Gailey, owner of Ambulatory Healthcare Strategies, ASC Central, and the ASC Podcast with John Gailey. And we have got a lot to get to today. AAAHC has just released v45 of the standards, and for the first time, there are artificial intelligence requirements in an accreditation handbook, effective for surveys on or after December 15th. There's also a big week of news from our side of the desk. The new ASC Central is live. The 2026 edition of the survey guide is out, and our September conference week is open for registration. Then Stark Law reform is back in front of Congress. A new survey says almost 2/3 of ASCs have canceled or delayed cases over anesthesia coverage. More than half of nurse practitioners are reporting burnout or depression. And then John's conversation with Amanda Penrod on leading across generations.
Well, it's good to be back with everybody. I know, Sue, I think in our last eepisode we said we were going on vacation and we were probably going to record a couple episodes. Can you remind me exactly how many episodes we recorded while we were on vacation?
I think it was 0.
I think it was 0, yes.
I can't say you didn't work a lot, though.
We were very busy. And admittedly, a lot of it was having fun with the grandchildren. So we were down in Myrtle Beach for the whole week and got some swimming in. Or at least I got some swimming in. And so did the grandchildren. So we're back to work here. I know it's been a while since we've talked. And, of course, that means that there's a lot of news that's been building up.
Yep, the vacation was definitely fun. Having having the family around and just being on the ocean is always relaxing. And we're hoping next summer to get even more of the family to join us. So, I don't think we worked too much on those first couple days, but, something always kind of pulls you back to the computer. But
exactly.
We enjoyed it.
We got a little behind on a few things while we were gone, no question. And that's, of course, the trade you make when you're on vacation. And hopefully all of our listeners out there have had an opportunity to get a vacation in like we did. But I did want to say, there is something that we were able to get done last week. largely because a lot of it is, was already prepared before our vacation, and that is the new ASC Central website is up and running. We got it up and running from down there. It was extensively tested by computers. Now we have human beings actually using it live, though we had spent a lot of time on it. There doesn't seem to be a lot of issues with it, thankfully. So it was a great exercise in updating an outdated site.
Yep, and we'll give you a lot more information about that a bit later rather than try to squeeze it all in here. And then we've got a news block with a common thread that you didn't really plan out that way.
I didn't plan it at all. Stark reform, the anesthesia survey, the nurse practitioner burnout numbers, every one of them is about who actually is doing the work and whether your paperwork says the same thing your schedule does.
Yep, and that's a nice setup for Amanda, too, because that's a people conversation at the end of the day.
Yeah, we recorded this conversation. Amanda and I sat down at the New Jersey Association meeting, which is probably about 2 or 3 months ago. And, we had a great time talking about what is happening with leadership. It seems to that's one of the big overriding themes in a number of conferences, state conferences that I've been attending. And we'll certainly be talking about it much more on the podcast over time, too. So let's start with our own news because I've been waiting to say some of this out loud.
Yeah, so let's get started. We've got 3 things, and they're all ours. Start with the website because listeners have been hearing you promise this one for quite a while.
That is true. And as I said, it is live now. It is at asc-central.com. So if you haven't been there for a while, you're going to notice a brand new page. You can still go back to the old site because some people are still signed up on that site. But you want to pay attention to that address. Because it is new compared to, the backdoor we had, which was conferences.asc-central.com. For folks who have never been there before, ASC Central is our education and membership site. It's where the boot camps live. We separated it from ASC Podcast a number of years ago, and it really has been, quite a nice way of being able to see the difference between our live conferences and our pre-recorded conferences and the podcast itself. But that's where our virtual conferences live, where our resource library lives, and where the memberships are managed.
And talk about the old site. People have been asking what's going on with that.
Yes, and let me deal with that head on because I don't want anybody to panic. The old site, which was on a system called Mighty Networks, stays open through March 31st, 2027. It just won't be updated anymore. You're going to want to use the ASC Central website. So if you're a premium access member, you keep your access over there through that date, and we're sending you login details. Many of you have already reached out with the emails that I've sent. But if you didn't get that email, make sure you email me at info@ascpodcast.com. And you're welcome to keep the old membership through March, but I do suggest that you cancel it there and join here because everything new is going to happen on the new site. And if you're in a boot camp or an education program, your access on the old site runs through March 31st, 2027 as well. There's a page on the new site that walks through exactly what is changing for the members, and we'll link that in the show notes.
And what specifically is better about the new site? Can you talk about that?
Yeah, if I had a couple hours. But the old site grew the way those things always grew, one program at a time until it was hard to find anything. So when new people signed up, I don't know how many times we actually sat in Zoom sessions with people, walking them through how to use the website. And we found that even we had problems navigating that site, and we're the ones that designed it. So clearly it needed a change. You would know that we had a credentialing program and you still couldn't find that button, for example. The new one is organized around 3 simple questions. Do you want a membership? Do you want leadership training? Or you just want to attend one of our conferences? Memberships, leadership training, and conferences. That's the whole menu.
And the memberships themselves have changed a little bit, too.
Yeah, they got a lot simpler, I think, and a lot more honest in the information we're providing. There's actually a nice little columnar webpage that shows you the difference between the two programs. The patron program is $25 a month. It's billed monthly, and you can cancel anytime. And it's an individual membership. It's meant for people that are long-term listeners of the podcast and want to support the podcast, and at the same time get access to a lot of information and resources, as well as our drop-in sessions. You get our full resource library, which includes policies, forms, drill kits, and templates. And then, of course, our weekly drop-in sessions. We did not do a drop-in session this last week because you and I were on vacation. And then a number of different, selected recorded conferences. Right now, there's 6 of them there. There's also a member forum, which you can type in a question and get some responses to. And, of course, the complete podcast library. And it's searchable now, so that you can go and search information on it. The other thing that we've included is, and we haven't talked about this yet here, but the survey guide, the new 2026 version. This has been going on for about 15 years, I think. We've been doing the survey guide. And the last update was in 2020. Now you have the option of purchasing it. It's available on Amazon, or you can get online access through any of our programs, the Patron program or the Premium Access program, which is kind of nice because you can search through the whole book, which you can't do, with the paper copy, obviously. And it's a great way of pulling things up in front of you. But I don't know, Sue. I'm still one of those old guys that kind of likes that paper. And I know you as a nurse also tend to like the paper documents too. It is nice. I think both of them have a good purpose, and I think we're going to find people probably will use both.
I think they both are useful, but I think people are really going to like being able to search, because if you're not quite sure where to look for something, and you can just search by a word. So, I think that's a great deal, the book being included. Even in the Patron program at $25 a month, I think people will love that.
Absolutely. That is a real deal right now. And, of course, it'll keep updated, whereas the book you'll have to purchase every year. So let's talk about the Premium Access program for a minute. And what's important to understand is it's one flat price for the entire surgery center. It's not per person. It's for your whole staff. So that gets you everything in the Patron program, plus all 3 of the boot camps, all of our recorded sessions over the last 5 years, plus Infection Control 101 and 201 in full, and a new annual mandatory education module for your staff and for the physicians, by the way. It's basically a learning management system similar to MedTrainer, and again, it's included in this program. And then there's a series of compliance tools and self-assessments. You get certificates for AEUs and IPCHs, depending upon the program. And every new conference that we release at no additional cost, and up to 5 hours of private consulting a year.
And now there's also the Leadership Mastery course on there, too.
Yes, there is. And that one deserves a real call out here. The ASC Leadership Mastery course is a 28-part video course, and it covers the 4 areas every ASC leader has to know cold: regulatory, clinical, staffing, and financial. It's the whole curriculum in one place instead of picking it up piece by piece over the 10 years, way most of us did.
And this one's built with the CASC exam in mind.
Yeah, it is. It's a structured preparation for the concepts tested in the CASC certification exam. The credential a lot of our listeners are either working toward or thinking about. And I'd say this even if you never set for the exam, the CASC blueprint is a pretty good map of what you actually need to know to run a center. And of course, works both ways. Prep if you're testing, and a gap check if you're not.
So how do people get to it?
There's 2 ways. It's included in the Premium Access program. So if you're a premium member, it's already yours, or you can buy it separately as a standoff program. All
right. And let's talk a little bit more about the other thing that took so much time with you this year, the survey guide.
Yeah, and by the way, you spent a lot of time on it too, Sue. So take a little bit of credit here take a lot of credit for one of the areas. It has been fully revised and expanded. It's now available on Amazon. And as I said, it is available on both membership and in an online version. And it needed a rewrite, not a touch-up. And here's why. The survey guide is built around the actual conditions for coverage, the interpreted guidelines, and survey procedures. Every requirement paired with the rule it comes from, what the surveyor is actually going to do, and a plain language explanation of what it means in a real center. When the guidance moves, when the payment rules move, when Appendix L gets updated, that book has to move with it or it becomes nice-looking paperweight.
And people do use it as a working document. It's not just a book that sits up on the shelf, or it shouldn't be, certainly.
Right, and that's the whole idea. It's the nicest thing people say to me during meetings is somebody will pull out their copy and they've got little sticky notes, stick it all out of it, or it's all dog-eared, or a lot of highlighters in it. I know that they're definitely using it. And if I see coffee stains on it, then I really know that they've been working on it. And that's exactly what I wanted when I created this book back in, I think it was 2011, the first edition came out. If you've got the 2020 edition on your shelf, it served you well, and now it's out of date in ways that matter. You can find information about it at jgailey, that's jgoehle.com, or search my name on Amazon, and it'll come up right away. And for the governing body folks, the second edition of the ASC governance book is coming out soon. It's almost done, but I wasn't able to get it out before vacation.
And the third one is a big announcement for September.
Yeah, this is the one I'd actually want you to put on your calendar right away. We're doing a live conference week. It's going to run from September 22nd through the 25th. 4 live interactive virtual conferences in a single week. And remember, if you're a Premium Access member or an AHS client, you get all of these conferences for free. Now, I do need to note that seats are going to be limited, so don't wait to sign up.
Okay, now can you walk us through those 4 days and give us a few more details?
Yeah. So Tuesday, the September 22nd, is Infection Control Oversight 101. So this will be the third version of it. We update it every couple years, and the last one was in 2024. That one is aimed squarely at the newly appointed infection preventionist, or somebody that wants to prove their qualifications as an infection preventionist. The person who just got handed the role, for example, as well as a person that's been doing it for a lot of years. Surveyors, of course, are going to want to see evidence of that training, and the certificate coming from this program is well established as one of the best training programs out there. And then on Wednesday, the 23rd, is Infection Control Coordinator Training, which is our 201 program. And this is an advanced day for people already running an IP program. It includes information about the annual risk assessment, surveillance tools, running an actual post-operative infection investigation, and complying with the CMS ASC infection control worksheet, which is the tool that the surveyor is literally holding when they walk through your sterile processing area.
And we should talk about how those two go together.
Yeah, they do. Taken together, 101 and 201 prepare you to sit for the CAPE exam. So hopefully you're seeing a trend here. You know, we're very serious at ASC Central on the podcast here about CAPE and CASC certification. Now, we are not part of those programs. We just very much believe in them and want to encourage you to, visit the applicable websites there. So the CAPE exam, or CAPE stands for the Certified Ambulatory Infection Preventionist Credential. Our dear friend Lori Rodricks presents both days. Lori is an RN, BSN, CNOR, CASC, and CAPE, and she's also a legal nurse consultant. And she is one of our surveyors also on our team here. And, you're not just getting into theory when you're attending these courses. She is citing, and she's talking about the things that are being cited and not cited in real centers.
And then Thursday is the QAPI one.
Yeah, this is brand new, and I don't know of any organization that has done a full day on quality improvement and peer review. This teaches you how to build, run, and defend your QAPI program. This is the other thing centers consistently get dinged on during surveys. So this program is going to help you to build, run, and defend your QAPI program, make you well prepared for your surveys, and of course have a program that really makes a difference in your organization. I am so passionate about quality improvement. You can imagine, Sue, how excited I'm going to be. Luckily, it is video, so you'll be able to see my hands waving as I emphasize all of the things that come with a good quality improvement program. And I'm not going to be doing it alone. Many of our staff over at AHS is going to be helping me with it, and we're going to be doing it in our new studio also.
Mm-hmm. And on Friday, we have a whole new one.
Yes, Friday the 25th is for our New York State Center. So I need to make that clear is that if you're not in New York State, this doesn't apply to you. So it's our Article 28 Mastery for New York State Diagnostic and Treatment Centers and ASCs. So as I said, this is very state specific. So if you're not in New York, it's not going to be for you. So if you are in New York, you already know there's almost nothing out there that covers Article 28 properly. And this is a full day of it.
All right, so where do people go to register?
All 4 are on our new website at asc-central.com, and we'll put a direct link in our show notes for today. And the reminder that I want to give you, if you're a premium member or an AHS client you're already paid for, log in first before you buy anything. Don't pay twice.
All right, so on to the news. We're leading with accreditation this week because if you're AAAHC accredited, something ended up in your inbox, or it's about to if you haven't gotten it yet. AAAHC has released v45 of the standards, and a system-generated notice is going out through 1095 Engage, telling organizations the new version is available for review.
Yeah, and they're very good about this. I think I have about 20 of these emails in my inbox because I'm I'm listed on quite a number of centers out there. So they've done a very good job of notifying everybody about the differences. So the headline date is December 15, 2026. The V45 standards become effective for surveys conducted on or after that date. So read that carefully because it's tied to your survey date, not your calendar year and not your accreditation anniversary. So if your survey lands on December 14th, you're on the current version V44, and if it's after that, or December 15th or after, it's V45. So the first thing to do is to figure out which side of that line you're on.
Yeah.
And 1095 Engage does tell you to do that, but might not be obvious. There's a lot of changes there that we have to think about.
So can you talk about what actually has changed? Tell us a little more about that.
Sure. So AAAHC says that V45 was developed with input from surveyors, accredited organizations, industry experts, and stakeholders, and that it's aimed at emerging technologies, evolving care delivery models, and the day-to-day challenges leaders are dealing with, which is a fairly standard way to describe the new edition. But there's one addition here that is not standard at all, and it's the reason I wanted to lead with this.
Okay, so what is that?
Well, V45 introduces new artificial intelligence standards. So this is the first in the industry. They sit in administration, governance, credentialing, and privileging chapters, and they give organizations expectations for governance and the oversight of AI tools. 5 areas specifically: transparency, validation, data privacy and security, human oversight, and bias mitigation.
So that's really a shift. We've been talking about AI in this industry for 2 years as a productivity story.
Yeah, we have. And now it's a compliance story also. And I'd point out where they put it because the placement tells you how they're thinking about it. Administration and governance. That means your governing body owns the program or owns the artificial intelligence policies. It's not the IT vendor's problem, and it's not something the administrator quietly handles. And then there's credentialing and privileging, which is the one that made me sit up. And that suggests the question of who is permitted to use those AI tools, what tools they're using, and how well they've been trained to use those tools.
So how many of our listeners are actually using AI in a way that will be affected by this?
So it's interesting you asked that, Sue, because just before we came down to the studio, I was talking to Jenna, my daughter, who is our director of development, and she's the one that's kind of jumped into V45 fully. And she pointed out that AAAHC wants to make sure you have policies, even if you're only using AI to help you write your emails, which I would venture to say a lot of us are doing that. And then she pointed something else out, which was, I thought, also interesting, is that, you really don't do Google searches anymore. You're actually using AI when you even go to the Google, homepage to do a search.
Yeah, even if you're not trying to. Yes.
And what she's led to believe is that that's also going to have to be addressed in the policies there.
So how do people get the actual standards to read?
Yep. So here's the tip I want everybody to catch because it saves you a lot of money. Free digital versions of the V45 handbooks are already available on 1095 Engage. Log in, go to the help curtain. Remember, that's on the right-hand side of the screen, and look under Released Handbook, not yet effective for your program. You do not have to buy a copy to start reading. If you want print, the V45 standards, both the regular ambulatory healthcare and the Medicare deemed status handbook, standards, as well as the advanced orthopedics handbooks, are up for pre-order now. They're not actually published yet, but they're available for pre-order, and you can put that order in. And AAAHC says print delivery is expected in late September. And to actually see the new standards walk through, their Achieving Accreditation program is running virtually September 14th through the 16th, and again December 10th and 11th in Las Vegas.
I know you like your to-do lists and your checklists, so if somebody has one thing they can do this month, what would you tell them to do?
Yeah, that's a good question. First of all, download the free digital version and read the revision summary before you read anything else. Every AAAHC handbook has an overview of what changed from the prior version, and that's 20 minutes. That saves you a lot of time. Then do the AI inventory. You're really going to have to spend a lot of time on those. Those 2 things put you most of the way there, and then you've got until December 15th, which sounds like a lot of time, but it really isn't.
So staying on the regulatory side, Becker's ASC ran a piece on August 11th asking whether Stark law reform is finally on the table. And the short answer, as I read it, is maybe, but probably not the part that everybody wants.
Yeah, that's a fair read of it. I thought the piece did a nice job of putting the history next to the current bills, which is the only way that this makes any sense at all. So here's a quick refresher for anybody who's new to this. Stark started narrow back in 1989 as a measure blocking physicians from referring Medicare patients to clinical labs they or an immediate family member had a financial interest in. Congress expanded it in 1993 to add Medicaid and 10 more designated health services: physical therapy, radiology, DME, home health, and so on. And that was effective in 1995. And here's the part that matters for how people live with it. It's been a strict liability from the start. A referral can violate the law even if the physician had absolutely no idea it did. That's no, I didn't mean to defense.
Which is exactly why compliance officers lose sleep over these technical paperwork issues.
Yeah, that's exactly why. And the current fight is about a specific carve-out. For years, physicians who owned a stake in an entire hospital, not a wing, not a service line, the whole hospital, could keep referring patients there under what's called the whole hospital exemption. And that drove a real boom in physician-owned cardiac, orthopedic, and surgical hospitals in the 2000s. The Affordable Care Act restricted it in 2010, no new physician-owned hospitals opening or expanding after December 31st, 2010, with the existing ones grandfathered under disclosure and growth restrictions. CBO scored that change as cutting the deficit by $500 million over 10 years.
And now there's a push to undo all of that.
Yeah, there is. Representatives Beth Van Dyne of Texas and Henry Kuehler of Texas introduced House Bill 4002 in June of last year with bipartisan co-sponsors. And Beckers notes that there are at least 3 bills moving under some version of the name Patient Access to Higher Quality Healthcare Act. They all target the same provisions, Sections 6001 and 10601 of the ACA and Section 1106 of the Reconciliation Act. The American Medical Association supports repeal, arguing physician-owned hospitals inject competition into consolidated markets, and pointing to research that charges at existing physician-owned hospitals for 8 common procedures ran about a third lower than nearby traditional hospitals. The American Hospital Association opposes it just as hard, and they say it lets physician owners steer profitable cases to facilities they own, while the community hospitals keep the complex, uncompensated, and Medicaid-heavy work.
So now most of our listeners are freestanding ASCs, not physician-owned hospitals. So why would they care about what happens with this?
As I was probably saying that last paragraph, Sue, that's probably what everybody was saying, is why is he spending so much time there? So there are 2 reasons, and the second one is the one I'd actually pay attention to. The first is directional. Every argument being made about physician-owned hospitals is an argument about physician ownership generally. And we are, in the ASC industry, a physician-owned industry. When the American Hospital Association says physician owners steer profitable cases, they're describing the ASC business model. So the rhetoric matters even when the bill doesn't touch you directly. Their second reason is the compensation side, which is much less glamorous and much more likely to affect us in our ASC industry. The Medical Group Management Association is pushing to simplify the group practice definition and to tie penalties to demonstrable harm rather than technical mistakes. And the American Urological Association is defending the in-office ancillary services exemption. And separately from Congress, CMS keeps moving the dollar thresholds in its normal annual schedule. Effective January 1st, the non-monetary compensation limit went to $535 a year, and the limited remuneration exemption went to $6,237.
And those are the numbers that actually show up in a medical director agreement or, say, as a holiday gift.
Right. Every year somebody blows through one without actually noting it. So here's my practical takeaway, and it's got nothing to do about whether the bill passes. Go pull your physician financial arrangements, your medical director agreements, your call coverage, equipment leases, space leases, anything where money or value moves between the center and a referring physician, and confirm that each one is in writing, signed, current, at fair market value, and commercially reasonable. And of course, make sure your lawyer has looked at that. That's the exercise. The reform fight will do what it does. Becker's read of the odds, and I agree with it, is that this goes the way it went in 2007, and again, ahead of the ACA. A lot of noise, and at the most, a narrow carve-out, probably for rural facilities, which always have problems with recruitment. Meanwhile, the Justice Department recovered $6.8 billion under the False Claims Act in 2025, with nearly 1,300 new whistleblower suits filed. That number doesn't care what Congress is debating. So, we talk about the False Claims Act quite a bit during our boot camps, Sue, and I think, we don't talk about it a lot on the podcast, of course, but those are things that administrators in particular had to spend some time reading, making sure they talk to the lawyers and looking at all of their agreements to make sure they don't have any issues there.
And our second story puts a number on something everybody listening has already felt. Becker's ASC reported on August 14th on SetAssure's 2026 Anesthesia Access and Sedation Survey. They polled 150 ASC perioperative and administrative leaders, and 62% said staffing gaps have caused canceled or delayed cases in the past year.
This is shocking to me. Well, it's shocking and not shocking, is that we knew that we had an anesthesia crisis, but the number actually surprised me. We've seen it, among our own clients, for example. We've even seen surgery centers that, not any of ours, but we've seen surgery centers have had to shut operations because they just can't get any anesthesiologist. This moves it out of the recruiting is high category and into the we're not going to be doing cases category now. Those are very different problems with very different price tags. The rest of the numbers fill it in. 53% reported closing rooms or cutting operating days. Nearly half scaled back surgical volume at least monthly, not once in a bad quarter. And 51% named the CRNA and anesthesiologist shortage as their single greatest challenge. Not reimbursement, not staffing in general, anesthesia specifically.
Yep, and the CEO of SetAssure had a line in there that really stuck with us.
Yeah, Mark Koch, who is their CEO and president, said, quote, "A year ago, the data told us facilities were bracing for a shortage. This year, they're living through it." I love that quote. Well, I don't love it, but it is very true. And then cancellations, closed rooms, and stalled growth are showing up on the schedule every week for half the facilities that we surveyed. End of quote. I think that's right. And I'd add that the financial damage is worse than it looks on paper because a canceled case isn't just lost revenue. You've already paid for the staff who showed up. You've often already opened supplies. You've burned a slot your surgeon can't get back, and you've got a patient who took a day off of work and stopped eating at midnight, and that patient tells people.
And there was also a shift in how centers are thinking about the actual staffing model itself.
Yeah, and we've seen this among our clients also and among our podcast listeners. A lot of questions recently. And so that's the part I found interesting. It's where this stops being a complaint and starts being a real strategy question, I guess is the way to put it. 60% of ASCs still run a traditional care team model involving an anesthesiologist, CRNA, and et cetera. But 41% of the leaders surveyed said that they'd consider a sedationist-led approach. And the procedure areas they named as most ready for that shift were endoscopy at 61% and pain management at 55%, which, if you think about it, makes complete sense. Those are the service lines with the highest volume of relatively short, relatively predictable cases where the anesthetic requirement is pretty well understood.
And SetAssure itself is built around that model.
It is, and you should weigh that because it's their survey. SetAssure launched in late 2025, pairing sedation-trained physicians, nurses, nurse practitioners, and physician assistants with standardized protocols, quality programs, and optional remote monitoring aligned to the Medicare conditions of participation, which is applicable hospitals, and accreditation standards. So they definitely have a horse in this race. That doesn't make the numbers wrong, though. 150 ASC leaders is a real sample, and the findings line up with everything else that we've been seeing and talking about. But do read it knowing who ran it.
So if a center is looking at a model change, where should they start?
Yeah, and we've talked about this a little bit on the podcast recently, but here's where I caution everybody to kind of slow down, because I've watched centers get very excited about a staffing model and then run into problems with the documentation, with the policies, with the regulations, with accreditation. So three things. First, your state. Scope of practice for who may administer which level of sedation is state law, and it varies enormously between the different states. Second, your own governing body approvals and your delineation of privileges. If you change who is providing sedation, the privileges have to say so, and the governing body has to have approved it. I've seen centers make an operational change on Monday and not touch the credentialing for 6 months. Third, your policies have to match your practice. Your anesthesia services policy, your sedation policy, your rescue and emergency policy, and your list of anesthesia services offered. If your chart says monitored anesthesia care and your practice is moderate sedation, that's the finding. And it's an easy one for the surveyor to spot. the model change may well be right for your center. Just don't let the paperwork lag that schedule.
So our third story stays on the workforce, but moves to a group we don't talk enough about. Becker's covered Medscape's Nurse Practitioner Burnout and Depression Report for 2026, which was published August 11th. 770 nurse practitioners responded, with more than half reporting burnout, depression, or both.
And the number in the headline is the one that people that should stop people. Nearly half of nurse practitioners said that they felt burned out for more than 2 years. More than 2 years. That's a pretty long stretch. That's a condition somebody has been living in and working through and probably showing up on your schedule during.
So let's talk through the rest of it.
More than 30% said that they're currently burned out, 7% said that they're depressed, and 16% reported both together. More than half attributed it mostly to job stress, and specifically 14% of male MPs and 22% of female MPs said that all of their burnout came from work. Of the people reporting burnout or depression, 22% are currently getting professional help, and another 20% have in the past. Almost two-thirds said it's affecting their personal relationships, while 72% thought that the impact could be mitigated. A fifth said it couldn't be mitigated at all. And this is really sad for, I think, our industry, and it's something that you're probably facing as an administrator or director of nursing on a daily basis.
Well, that last number is so concerning.
Yeah, and I don't want to blow past it, but let me give you the two findings that are actually actionable for somebody running an ambulatory surgery center, because a lot of this report is about the profession generally, and two pieces are squarely about management. First, only 16% of nurse practitioners believe their employer sees the impact of burnout on staff. 16%, and that's down from about 20% in the 2024 version of the same report. So it's not just low, it's getting worse. Second, the top three drivers they named were too many administrative tasks, insufficient compensation, and too many hours.
And what are the fixes that they're asking for?
Increased compensation to relieve financial stress, a more manageable schedule, and higher patient and lighter patient loads. Now, here's the finding that I think most leaders get wrong, and I put myself in that group historically. Nearly half of NPs said that more open communication with their coworkers would not help with burnout, and 66% said it wouldn't help with depression. So the standard management reflex, let's do a listening session, let's do a team building lunch, let's talk about it. The people experiencing this are telling us that that isn't the lever. The lever is the workload and the administrative burden.
Which for an ASC is a lot narrower problem than it is for a hospital.
It is, and that's the good news, because we can actually move it. Most of us don't employ a large NP population in our ASCs, but a lot of centers have nurse practitioners and physician assistants doing preoperative assessments, doing H&Ps or H&P updates, doing first assist work, doing discharge teaching, doing post-op phone calls, and a lot of what fills their day is documentation that we've created. Forms with redundant fields, a policy that requires 3 signatures where one would do, a history and physical process that's been layered over 5 times by 5 different people. And so here's my practical suggestion, and it costs nothing. Sit down with your advanced practice providers and your nursing staff and ask one question. What do I make you document twice? Just that one. Then go fix 2 of them this quarter, and while you're in there, make sure that the 16% number isn't you. If your people don't think you can see it, you can't manage it. In just a moment, I'll share my conversation with Amanda Penrod of RFX Solutions, recorded at the New Jersey ASC Association meeting. Amanda is one of the best-known voices in the industry on leadership, and we got into something every one of us is going to face, how we lead across as many as 5 different generations under one roof, and how we hand this industry off to the people coming up behind us. We'll get right to it after the short break.
Every ASC professional knows that running a surgery center takes knowledge, skill, and a strong support network. That's why we created asc-central.com, a place where ASC leaders and staff can learn, connect, and grow together. ASC Central is a comprehensive hub for education and professional development in the ambulatory surgery industry. Our leadership boot camps, on-demand conferences, and membership programs are designed to meet the needs of administrators, nursing leaders, medical directors, business office managers, and anyone committed to excellence in outpatient surgery. Our leadership boot camps are guided, mentored programs that help develop the next generation of ASC leaders. Whether you're new to your role or looking to refine your skills, these boot camps provide the structure and insight you need, and many of them offer AEU credits for CASC certified administrators and IPCH credits for CAIP certified professionals, supporting your ongoing professional certification. ASC Central's on-demand educational library gives you access to in-depth programs on compliance, quality improvement, infection control, credentialing, finance, and more. These full-length virtual conferences are designed to be both informative and engaging, not just check-the-box webinars. Many also include CASC and CAIP continuing education credits. For those who want ongoing learning and connection, ASC Central offers flexible membership programs. The patron membership gives you access to Zoom discussions, key conferences, and a robust resource library. The Premium Access membership adds full access to all boot camps, private consultations, staff training, exclusive content, and ongoing support from top experts in the ASC field. If you want to be part of a community dedicated to raising the bar in ambulatory surgery, visit asc-central.com or email us at info@ascpodcast.com. ASC Central, bringing ASC professionals together to learn, grow, and thrive.
Our focus today is leadership, and specifically the basic, everyday leadership challenges facing the ASC industry right now, and why mentoring has to be part of the answer. We spend so much energy innovating inside our operating rooms, new service lines, more complex cases, total joints, spine, and of course now cardiac. But we've kind of fallen behind on innovating how we actually run the business and develop our people. A whole generation of leaders who built this industry is reaching retirement age, myself included. And in a lot of centers, there's no one being groomed to take the reins. At the New Jersey Association meeting, I sat down with Amanda Penrod of RFX Solutions to talk exactly about that, leading across the generations, mentoring and reverse mentoring, and a take she has on hospital versus ASC training that's a little controversial. I'm not going to spoil it. Here's the conversation.
I'm here at the annual meeting of the New Jersey Association of Ambulatory Surgery Centers, and I'm here with my dear friend Amanda Penrod with RFX Solutions. Amanda, you've been on our podcast a number of times, but there probably are still people out there that don't know who you are, so please introduce yourself.
Thanks, Sean. Always such a pleasure to be on the podcast with you, and of course, come to the annual conferences as well. Mm-hmm. But as John said, I'm Amanda Penrod, so CEO and founder of RFX Solutions, and we're a regulatory and compliance and credentialing platform. But prior to this, I spent about 25 years in the space, and definitely absolutely love being here and supporting it. And
our businesses, really overlap so much. Yep. You're on the technology side of regulatory. We're on the more that human, one-on-one with the leaders, the directors of nursing, and the administrator side. So it's always great to talk to you. We use your tool a lot, and it's a great tool. And you're here talking about something somewhat different. You're really quite a well-known speaker on the topic of leadership in ASCs, and you've talked about it on the podcast, but I don't think we can talk about it enough. So you did a presentation, a very well-attended presentation here at the association. Talk a little bit about what your topic was and what some of the key takeaways were.
John, today my topic really was on leading across different generations. Mm-hmm. And because I feel it's so important, because for the first time, we're really seeing 5 generations inside our businesses, and but predominantly 4. Yeah. And really felt it was important to kind of bring this to the forefront of how we think about where we're going in the industry as a whole, because we're advancing what we're doing inside our operating rooms in terms of what kind of surgical procedures and that are happening. We're seeing cardiovascular over the last 5 years. We've seen obviously an accelerated rate of orthopedic procedures, spine, neuro, to the levels of complexity, but we're continuing to fall behind in terms of how we manage our business and how we look at that. And so I felt it was just so important to bring to the forefront from a leadership perspective what these differences are across generations, how we learn, how we process information, and how we can do this better to get ahead of what we're doing, and whether that's in how we think about succession planning, our mentoring, and just quite frankly understanding how we process information different across the generations, and how we can do a better job of it inside of our surgery centers.
There's no doubt that one of the biggest challenges we have in the industry is the aging out of our older leaders.
Yeah.
And the new generations coming in. So a good understanding of the generations and how they approach leadership differently, how they approach their jobs today differently, I think is important. So, what was your perspective, or what were you trying to get across the audience on that?
Yeah, so it's such an excellent point, and it was a lot of great conversation even in the audience today around those various topics and the challenges, even if we have like millennial leaders and trying to lead up across generations a little differently there. But a big thing for me, and in that room, I mean, there was quite a few, boomers, and then we've got the Gen Xers in the room.
Yeah.
And I talked to them about the fact that even when we think about how we learn, and as we learned as children, as an example, paper, as we go back to information was in encyclopedias. I know it sounds silly to say that, but the amount of information at the forefront and at our fingertips, but understanding, this love for, we've had these paper processes, binders, well, it made sense. But when we really start talking about how information and knowledge is acquired, even when I kind of asked the audience, I said, when you hand a Gen Zer, an example, a binder, they're like, I don't even know what to do with this.
Right.
And I said, and then also in their defense, when they're very evidence-based, they want information and knowledge at their fingertips. Like they look at that and they're like, how do I get that out of there? They don't even know how. And when we think about how they learned to acquire information, they had computers and technology right in front of them since the time they were very little.
At their fingertips. Yeah.
And so one of them, some other conversations, we think about EMR, and we think about even our new docs graduating school. They can just very quickly adapt, and away they go, where others are not. So just collectively as a whole, I told them, I said, so when we've had to learn from basic root memorization, and comprehension differently because it's in paper form, and I'm like, but when we walk out that door, so does all that knowledge.
Yeah.
And it walks out with us. And I said, so if with all the advancement, I said, we're going to see growth in ASCs like we've never seen before.
Yeah, absolutely.
And I'm like, more service lines, more complexity, patient selection complexity. And so as this is going, we're innovating in our ORs. If we don't innovate the business and what we're doing there, how are we going to keep up from a quality, patient safety? I said, we can't. From a retention, from an organizational cultural competency, we can't. And so the biggest thing is understanding what are our challenges, and with that.
Well, and I think what you're also getting at here, probably a primary takeaway here, is that the leadership of the past. And I'm one of those. You know what I mean? We either have to learn new skills or adapt to it, or obviously look to train the next generation on the basics of the business and let them take their new way of doing things and run with it. So how are they going to do that?
Yeah, so I talked a lot today about 3 different types of models, and we think about mentoring more in the traditional sense of mentoring, and a lot of that is mentoring down because we've got a lot of experience, people are more seasoned in it, so we mentor to educate, to bring them up. But I also broached the subject of reverse mentoring, and then also some peer group learning. And I talked to them, and I used some examples, and we talked about things like EMR implementation as an example. So with that, and I'm like, it makes the most sense. Who do we typically choose to lead it? We're smaller organizations, and collectively the rooms, like, I would choose somebody that's more senior and seasoned and knowledgeable. And while that sounds great, we need them as part of this. At the same time, that's not how they process. That's not how they learned.
Right.
And I said, okay, so, but what about pulling a Gen Zer in? Because I know I can hand them my phone, and they can do stuff on my phone that I didn't even know that thing can do. And while they may miss some critical steps, it's like, what do we do in that process? But by way of this, we're starting to mentor across the generations. We're also demonstrating a flexibility and adaptability. And then the other things I challenge them with in this is when we think about mentorship, we also think about it as a shorter point in time. But if we're really going to continue to advance this particular aspect of the healthcare industry, what we need to be looking at as well is going, when I do that annual evaluation, preferably more frequently than that, but when I'm doing that, are we asking them, what do you want to do in 3 to 5 years?
Yeah.
And then thinking about how can I start plugging them in, even if it's 30-minute things every month or 15 minutes here and there. I said, we think about it as something that has to be so overly formalized, but what are the other small things that we're doing to start to engage? And by way of that, we get, more mentorship in terms of what we're doing.
So, as a key takeaway for our audience, first of all, when we look around our attendees today, you see a real shift, I think, toward a lot younger people. I've noticed that very dramatically this year than perhaps in the past. And I think part of that is that, obviously, a lot of the people that started the industry are moving into the retirement ages. Look at myself, at 65, it's time for me to start turning the reins over. But how do we identify the right people among the many that are out there looking for a job, and how do you've already talked about the mentoring, but I think identifying that person that's going to have those skills, and, are they going to come from the traditional people that we're used to, nurses coming up through the ranks, for example. We've even had in our company, we've had surgery centers that have come to us with fresh graduates coming out of college, and I got to say, they haven't necessarily been bad at the job.
Yeah, I love the fact you brought this up, because that is definitely one of the things we talked about, and things that we're seeing also is, and we're hearing. I mean, we're a national company. We're working with ASCs all over the United States. We're at conferences, and we have these young nurses just out of school, 2 to 3 years, and then they're doing well in their OR management. They're doing well in other things where they're performing, and with the growth in ASCs, we're almost forced to also be looking to or moving those individuals into these roles in order to keep up with the growth. Yeah. When you're talking about identifying, I think there's a couple things. Traditionally, we also were looking for people with experience. Yeah. We're looking for people to check certain boxes. Instead, I think we need to be even innovative in that thought process. Yeah. And part of it is we need to find people who also want to do that. Yeah, and knowing that they may be afraid, and this is something I talk to the audience about, is I'm like, you may have somebody in your business office, and they don't want to say anything because they see a business office manager, they see the admin, and they see the delta of knowledge. But I said, what happens when we start asking those questions? What do you see yourself doing? And it's like, well, I would like to do it. I don't know if I can. Well, sometimes they need encouragement. Right. And I said, or to be put, again, in the right systems to help with some of the mentoring. But really, for me, it's finding people who want to be part of that impact, and those are going to be they're going to be more motivated differently versus just looking, and that more we've looked more hard skill. Soft skills important, but I think clinically we were looking more hard skill. Like they did great in the things that they did from really more tactical as a nurse. They were great with soft skill physician relationships, running those OR, patient safety, but I think we have to come outside of that box and go, okay, we don't necessarily have the opportunity to know, but what other, do they have that desire, and then looking for those individuals with that interest, and then plugging them in. I can't say enough about different education, and with technology, getting them plugged into networks, things like that.
There's always been a perception that some of the best nurses that come into our industry come from the hospital first, and that could be said for a lot of nursing positions. Is that you do your internship almost with the hospitals. You spend your 5-10 years there, and then you move to wherever you want to end up being. And then there's also this perception among some people, especially in the operating rooms, that, as I'm getting older here, I want to slow down. Maybe I need to go to work in the surgery center. And we all know that never ends well. So, as we are competing with hospitals for talent, how do you see that dynamic playing out? Where do you see the role of people coming from? Should nurses even be considering going into the hospital environment in the first place today?
No.
I love it. I totally agree with you.
I can affirmatively say no. In fact, I didn't talk about it today, but I will actually be talking about this in Florida. I've talked about it at some other conferences. Yeah. And the answer is no. Yeah. What we need to be doing as an industry and thinking outside the box with this, we need to get in front of them as they're coming out of school. Yeah. Going to those job fairs, going to have discussions with them, educating them, bringing them in, and actually offering some of those interning, partnering with those programs, because at that point you're also getting nurses where they aren't in the hospital setting and they're not learning things in the way that they process and the way that those workflow, all of that's going, or having even limited, they may clinically be excelling, but are they excelling in in the dynamics of what we see from how we function, a regulatory perspective, and the list goes on in the ASC environment. Right. And we all know there's so much growth. I think we need to do better as an organization, getting in front of that and saying, you know what, we don't want you to go train at the hospital. Yeah. I want to train you here in the ASC as that scrub tech, or in central sterile, or in business office. I want you to learn it here first. Yeah. And really establishing those type of programs. So.
Yeah, that's fascinating. First of all, you said it so quickly. And I feel the same way, that I'm not sure. And my daughter, my wife, they all went through that normal course where they went through the hospitals first. And I think they'll be the first to say it didn't give them very good training for dealing with the ASC environment. And that's not the be-all and end-all right now. I love it. And, of course, what you just said is very controversial. But I think it's a very good point.
Well, but I look at it, too, John, even when we talk about, and I tell people this, oftentimes, we think of the ASCs, and let's just, whether it's clinical or even when we think about technology, as an example, what we traditionally see is the EMR and, in these big systems, and everybody goes hospital first, and then we always are trying to retrofit everything back down into the ASC,
well said. Yeah.
Versus saying, you know what, our ASCs are now on the forefront of this, and we are seeing growth in the ASCs happen at exponential rates, de novos going in, service lines, and we need to change that. And as an industry, we need to change how we're thinking about it, and the best way to do it is with our people. And saying, you know what, we got to think about the industry first, not hospital first, but industry first. And whether it's technology, whether it's how we train our people, going, you know what, we can do this. Yeah. And we're going to have to do it, because in the next 5 to 10 years, if we don't, we're going to find ourselves behind.
And I think so many of our listeners that are listening to this right now have had to untrain certain habits that have come from the nurses come from the hospital. Will totally agree with you. So, I think I have to ask this question of every person I interview nowadays. What's AI going to do? I know you and I are going to be talking about AI at the multi-state conference in December, but tell me what your quick thoughts are here on its impact on leadership.
I have lots of thoughts.
Yeah,
on
I
AI.
know. You have to keep it short.
I will have to keep this short, because we're going to talk about it at length a little bit later this year.
Yeah.
What I can tell you is AI is absolutely going to be a game changer with Anthropic's move in February, with obviously the release of Claude. It is moving that industry ahead faster than we ever expected. And I share this with people. So as a company, we've been using AI in the background for like 2 years, and hugely supportive of it from a productivity standpoint, and there's very responsible ways to do that.
Right.
And here a few months ago, and so it's kind of piggybacks into the generational things and that and the topic itself, I would get on the systems, and of course for myself, I was trying to prompt it, because I'm like, people say, okay, I can do this for different things that I'm doing with my job. And what it would produce for me was terrible. Yeah. And so I had a scenario where I literally had some reverse mentoring and with one of my teammates, and he's very versed in it. And he said, look, can I teach you how to prompt this? Yeah. And it was like, I welcome it right now, because I was so far behind, I was bottlenecked. Well, in today's session, I actually shared this with them, and I used it as a reverse mentoring example as well, but also in being innovative and thinking about technology. I told them, and I said, so once I was learning how to prompt it, and of course I'm doing it in controlled, it's a paid subscription, I'm not out there on I'm not paid.
Important to know.
Those things are important to know. But when he started teaching me this, so as a company, I'm expanding roles as we're growing, and what I found so fascinating, once I got it and I started understanding it, so for instance, like in my implementation team, I have different levels, like implementation 1, 2, senior, and then can go into like team leads. Well, what it allowed me to do was create this job description, and then it would create multiple ones for me, very consistent for my company, and then it would build the competencies and what it meant to go from 1 to 2 to 3. Once I got this done, literally within an hour, that's prompting it, it's creating all this whole entire structure, I have it, and it is consistent with what I need legally and from an HR standpoint. And those things became eye-opening for me, because it literally starts 10xing my productivity. And I'm like, I think from a data perspective, from a productivity perspective, used responsibly, it's going to change what we're doing. But when we talk about generations, this is where our Gen Zers and young millennials can help us push this and think about it different. And then you've got your boomers and your older millennials as well as your Gen Xers, and it's like, okay, partnering those together, and that knowledge, okay, this is what we understand for the industry, but then how do we move it together? And it's going to be a game changer.
Yeah, and I think there's a lot of naysayers out there. You and I were having dinner one night just this last week where, somebody said, oh, it'll never replace people. And unfortunately, we know very well that the scenario that individual is showing is indeed, behind the times. I love your concept of reverse engineering or reverse mentoring. I've never heard that term before, I got to admit, but it's happening in our company. We see it with our younger people, teaching us every day things that we didn't. Yeah, but you as a leader have to be open for that. You can't sit on your high horse and just say, I've been doing this a lot longer than you, and you have nothing that you can teach me. That's just so wrong.
No, when I think about leadership, John, one of the things I'm really passionate about, and we look at our own emotional intelligence, there is no other single role where we literally have the ability to impact the trajectory of the future of people's lives, the number of hours we spend in there, what we're doing. And when we think about ASCs, I mean, this is our patients, our providers, and I challenge them, even when we think about the mentoring, whether what we're using, how we're going to be innovative, we're innovating in our ORs, how are we innovating our businesses, and then if we're going to develop competent organizations, these tools need to be there. Yeah. And even, I said to them, I said, when you guys go to Google, I said, you do a question now, what happens? And the room's like AI, and it answers it. And I said, right, what we're learning is we can have more information. We got to be responsible with it. Right. But we can have more information and faster. And we build, by nature of that, stronger, more knowledgeable organizations and the competence in it. But as leaders, you have to be open to those type of things. Yeah. And then understanding where we're going. And as a leader, we all are going to exit this. Yeah. And we may exit because it's retirement. We may exit. We want a new opportunity, challenge, whatever it is. What are we leaving behind, and are we advancing it to keep up pace with how the industry is advancing? What are we doing? And these tools will allow us to do a lot of those things, even though, in that conversation, no, there's things that we can't replace. It's not going to start an IV. Right. But what I do tell people is, like, what if the business as a whole was stronger? So under the hood, your business, all that paperwork, what if now you as a leader and your team, we could be doing the things that only people can do? And then let technology do what it can do. Yep. How does that change what we do every day innovatively and through technology, automations? I mean, what other information, what evidence-based information do I have that even makes me stronger as an ASC? Yeah. And but I think some of it's the fear of the unknown. I think some of it's fear of losing your job. Instead of going, wait a minute, if I use this, what other things do we do to value and get back? You and I were kind of talking, and we're seeing this, and I had the opportunity to go to HIMSS here a couple months back, and the amount of AI, and the thing that impressed me the most that we're seeing come to the market is the ability to do more face-to-face interaction, because they're using it and charting. And you had mentioned, when we were talking, like the vets, and they're literally on the floor playing with the animals, and they're talking into this, and then a few hours later you have the most detailed note from that visit, because we can actually capture it. Yeah. So, but we've got to be open to it and realize that if used responsibly, there's a lot of amazing things we can do.
Well, and I truly feel that AI can take away the things that I don't want to be doing. I want to be talking to people, like to your point, I want to be talking to people. I want to be coming up with innovative ideas. I don't want to be doing a whole bunch of documentation all the time. But the AI can do that. Sounds like that's probably a pretty good place to stop. Yeah. As always, Amanda, it's great having you on the podcast.
Yep, sounds wonderful. Thanks, John. Appreciate it.
My thanks to Amanda Penrod for that conversation. Sue, the part that really lands for me is her point that there's no other role where you can have as much ability to shape the trajectory of other people's lives as you do as a leader in a surgery center, and yet nobody hands you a manual when you take the job.
It's so true. Most of us came up through the clinical side or the business side, and then we just got handed the keys and told to just get going.
Yeah, I tell these stories all the time in conferences where, how many of you were groomed for this position? How many of you went to college for this position?
Yeah.
And, well, first of all, nobody ever says that they went to college for it, and very few of them were ever groomed for it. They didn't have time. Usually they were a nurse on the floor on Friday, and on Monday they were suddenly the director of nursing. And that gap that we're talking about here is the whole reason we built our leadership programs here at ASC Central. When Amanda talks about the aging out of our leaders and the fact that there is no formal training path for running an ASC, that's precisely the hole that we're trying to fill with the boot camps. We have an administrator boot camp, a director of nursing boot camp, and a business officer boot camp, 3 complete 4-day virtual programs, plus the new ASC Leadership Mastery course, which is the whole curriculum in one place. It's the finance, the governance, the survey readiness, and the people side, the things nobody ever sat you down and taught, so you're not learning them by getting burned. It's a way to give somebody that mentoring even when they don't have an Amanda down the hall. All of it is included in our Premium Access program, and it's all on the new site at asc-central.com. If you have someone on your team you're trying to bring along, or if you're that person yourself, go look at it.
And that's exactly the kind of investment Amanda's been talking about, getting ahead of the gap instead of scrambling once somebody gives notice.
Let's take a short break, and when we come back, we'll have a very quick list of upcoming events in the ASC industry.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff and other events in the ASC industry.
So upcoming on the podcast, our next episode, 287, is going to be a deep dive on emergency preparedness and the condition for coverage, which is included in 416.54, and what surveyors are actually asking for. And episode 288 is my interview with Darren Smith with SIS. And that's going to be on QAPI and quality studies, which pairs up really nicely with our QAPI conference in September. And as always, we'll have the latest news and what we're seeing out in the field.
So for other conferences, we have the Georgia Society of ASC's summer meeting, August 20th through the 21st at Hotel Emmeline, Charleston, South Carolina, and the Illinois ASC Association is the 20th and the 21st. So it probably will have started by the time you get this at the Renaissance Schaumburg Convention Center Hotel in Schaumburg, Illinois.
And I'll be attending that conference and doing moderating a session as well as doing an administrator training program on the Friday morning. And the Texas ASC Association's annual conference is August 26th through the 28th. At the Margaritaville Lake Resort in Lake Conroe in Houston, Texas. I'll be there also, and I'll be moderating a session with accreditation organizations.
And the California Ambulatory Surgery Association's annual conference and exhibits is September 2nd through the 4th in Monterey, California.
And I'll be there doing a special episode from Monterey. Love Monterey. It'll be a lot of fun. Yeah. And don't forget about ASC Central's live conference week. It's going to be September 22nd through the 25th. Broadcasting from our new studio, by the way. It's going to be performed virtually, and if you're a Premium Access or an AHS client, members all attend for free. So during that week, Tuesday, September 22nd is Infection Control Oversight 101. Wednesday, September 23rd is Infection Control Coordinator Training, IC 201. Thursday, September 24th is Quality Assurance and Performance Improvement, the QAPI Conference. And on Friday, September 25th is for New York State Ambulatory Surgery Centers. It's Article 28 Mastery, which is an overview of the regulations for New York State diagnostic and treatment centers and ASCs.
And the Pennsylvania Ambulatory Surgery Center Association's annual meeting and educational conference is October 4th and 5th at the Eden Resort in Lancaster, Pennsylvania.
And we will have a booth there, but we won't be doing a special episode from there, unfortunately. The Atlantic States ASC Conference, which is North Carolina, South Carolina, and Virginia, their conference is October 8th through the 9th at the Embassy Suites Raleigh-Durham Research Triangle in Cary, North Carolina.
And the Oregon ASC Association's annual conference and trade show is October 15th and 16th at the Holiday Inn Portland in Wilsonville, Oregon.
And I'll be speaking at that conference, as I have for the last couple of years. And the New England ASC Conference is October 23rd at the Hilton Boston Dedham in Dedham, Massachusetts. And both Lori and I will be speaking at that conference.
And Becker's 32nd annual meeting, The Business and Operations of ASCs, is October 29th through the 31st at the Swiss Hotel in Chicago, Illinois.
And I'm looking at that 32nd annual, Sue, and thinking to myself, man, I remember being at the first one, 32 years. Wow. The Ohio Association of ASC's annual education conference is November 11th through the 12th at the Ohioan Hotel and Event Center in Lewis Center, Ohio. Unfortunately, I'm not going to be able to make it this year because I'm going to be out in Washington, but Lori Rodericks will be there, and we'll have a booth there also.
And the Washington Annual Education Conference and Trade Show is November 11th through the 13th at the Tulalip Resort and Spa in Tulalip, Washington.
And as I said, I'm going to be there, and we'll be doing a special episode from there. And I am also doing a presentation. And the New York State Association of Ambulatory Surgery Centers annual conference is November 17th through the 18th at the Desmond in Albany, New York. And there is a pre-conference on November 16th, which is going to be a CASC review course and a CAPE review course, so something very new for that association. For more information about all of our conferences, all of our virtual conferences, visit asc-central.com. Thank you for joining us for this episode of the ASC Podcast with John Gailey. We hope you found the discussion valuable, and if you did, please share it with your colleagues and be sure to subscribe so you never miss an episode. We genuinely appreciate your feedback and topic suggestions. Feel free to reach out anytime at comments@ascpodcast.com.
And we want to thank our outstanding team whose dedication makes this podcast possible. Sound editor Susan Cronkite, executive producer John Gailey, and our research team Sue Cronkite, Jenna Alvarez, Christina Norman, Judy D'Ambrosio, Mike D'Ambrosio, Zach Kelleritis, Jim Masters, Stuart Rosenberg, Amy Cronkite, Lori Rodericks, Kathy Fody, Donna Macchio, Kelly Frankenfield, and Tony Lyons.
Our theme music is by Media Sushi and Mike Noah, and the ASC Podcast with John Gailey is hosted on Podbean and is available on all major podcast platforms. Thanks for listening, and we'll see you in our next episode.
This episode of the ASC Podcast with John Gailey is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Gailey, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.